thank y'all for your patience. I want y'all to know I know this is frustrating from a student end. I want y'all to know that we're not taking it lightly. We're not just, rolling through it, hoping things work, that we're working behind the scenes. So I know, as aggravating as it is, that I just want y'all to know that we are working, and you won't be at a disadvantage for getting those lectures late. Everything will be, they'll all be there, and all the content for your exams will still be the same and all of that. So, so I posted for the evening class and for the Walker class. I just got somebody that says they don't see the PowerPoint. Can everybody else see it? Send me a thumbs up real quick if you do. Everybody's got a thumbs up? Alrighty. April, if you're on your phone, sometimes it won't show. Yes, I can hear you. I'm not sure, but I will definitely. I didn't hear you. I'm sorry. It's still showing over here. The PowerPoint's going to be made available to you, I promise. So you'll have, even if it comes in and out, you'll have access to it. Okay. All right. So yesterday we covered chapter 1 in our lecture, and it was just the general principles of pharmacology. So we didn't go into a whole lot about what your job was as a nurse. We didn't talk about really a whole lot about your job as a medication administrator. We didn't talk a whole lot about education. We talked more about in giving medications, what was happening within the body, and what was happening, what could happen to the body because of those medications. So today we're going to talk about more specifically your role as a nurse. So it's we won't really be picking up where we left off. There's one example that I want to share at the beginning, because I'll be referring to it as we go through education today, and as we go through everything that I'm going to talk about today. I want to use it as an example throughout. So yesterday I talked about Tylenol. Everybody should be familiar with Tylenol. It's one of the most common drugs in the United States. So I showed my class, I showed them a regular bottle, which is a brand name bottle of Tylenol. And then I told them that usually I shop and get the cheaper stuff at the DG or at Walgreens. And then my children have Tylenol as well. And we talked about the brand name is Tylenol. We talked about that the generic name is acetaminophen. And the generic name is given by the FDA. And it is what's used across the board, no matter who manufactures it. The name of that medication, the generic name and the recognized name is acetaminophen. So throughout this class, and I'll share this with you, Miss Charlie, too, as you begin lecturing. I'm not sure how long I'll be lecturing. This book here is just I don't want y'all to buy this book. I just want y'all to know that I'm pulling some information from it. It's 140 must-know medications on the NCLEX. So it's some people that got together. It's not an official book or anything like that, but it's some people that got together, and they said this medication shows up on the NCLEX. It appears to show up over and over and over. So I'm going to be referring to this book today. That way we can talk about a Tylenol example specifically, okay? So for Tylenol, in this book, the information that it gives is the generic name, which is acetaminophen, the trade name, which is Tylenol, and then the indication. As a nurse, and all of this is going to be on my PowerPoint, but I just kind of want to give an introduction first. As a nurse, you should always know the indication of the medication that you're given. You don't ever want to be the nurse that when your patient says, "Why am I taking this?" you're like, because they ordered it. You want to be the person that can say, "You're taking this for ... It's indicated for ... So, what do y'all think that Tylenol is indicated for? This is knowledge that you already know outside of nursing. Type in the chat bar. Like, what would you say the indication is? Fever, perfect. Pain, perfect. Perfect. Those are the two main ones already. So those are indications. So you know that as a nurse, you should know that, correct? So a lot of medications are not as easy as Tylenol. And you're not always going to know their indication. So you're going to go to your drug book and you're going to go to your resources that are available to you so that you can, know the indication for your medication. Something else you're going to need to know is the action of your medication. And that's where pharmacology stresses people out. So for acetaminophen, a broken down version is this. The action is to inhibit the synthesis of prostaglandins, which may play a role in transmission of pain signals and fever response. So that just tells you how it works within the body. And so when we're talking about the mechanism of action, that's what we're talking about. How does it make that, whatever it's indicated for, how does it work? How does it do that? So it does it by inhibiting the synthesis of prostaglandins, which we're going to talk a whole lot. I say a whole lot. We're going to talk a little bit. I'm going to share some stuff. But in A&P, you vaguely remember, I know y'all probably don't remember it all, but remember when y'all talked about like the synapses and this sends the signal to this and this does this and it's kind of like a chain reaction. And that's kind of the same way that medications work. They bind to receptors, and the binding of those proteins and the binding of those prostaglandins cause a reaction within the body. So that is their action. So their therapeutic class is this particular drug is an antipyretic, and it's a non-opioid analgesic. So a drug can be in more than one class. So that the reason I want to kind of point all this out at the beginning is because when you're administering drugs, a medication might be an antidepressant, and it also might be an anti-epileptic, which is a seizure medication. So you don't want to go in and say, oh, I'm giving you this for seizures, and your patient says, oh my God, I had a seizure. No, you're on it for your depression. It's not always indicated for the same thing, okay? So those are kind of a lot of the considerations that we're going to talk today when we talk about drug administration, okay? And then I'm going to leave it, our next slide. So the very last thing that's listed in this book are the nursing considerations for that drug. So as a nurse, you'll always have certain things that you're considering. If this happens, I will, ... and you're always anticipating what could happen next. So I just wanted to give this example of acetaminophen so that whenever, for my Walker class and for my evening class, if you haven't gotten a chance to watch that first, I keep wanting to say podcast, whatever it's called, that first recorded lecture, you'll know when I say, remember when we talked about Tylenol yesterday, that's really all I told them was, just kind of discussing all those different aspects. So that being said, we're going to get into chapter 2, which is administration of drugs. So, sip of water real quick because I talk a lot. So one of your roles as a nurse is going to be to administer drugs. There are 5 rights of drug administration, but really, truly, there are 6. So as far as I'm concerned, there was 5 rights for probably 50 years, and then they added 1. So we have 6 rights of drug administration, okay? Those rights, we need to make sure. So our rights are also they are the things that we need to know to safely administer these medications. If we are missing one of these, then we dropped the ball. We screwed up, okay? We need to make sure that we are administering drugs to the right patient. We need to make sure that we are administering the right drug. We need to ensure we're administering the right dose by the right route with the correct time. And then we must accurately document. If we do not accurately document, then we didn't give the medication. And I'm going to give a lot of examples for all of these things. Drug errors, I wanted to change what I was lecturing the last time. Last time I taught this in class, I did some statistics of how common drug errors are in the United States. and how often they happen and how often they cause death, and it is mind-blowing. But it's kind of not at the same time, because just in my nursing career, I've seen a ridiculous amount of drug errors, okay? And I'm sure that Miss Charlie has as well, unfortunately, with, you know, how quickly things move and how it happens, unfortunately, and it shouldn't happen. But one way that we prevent it from happening is to ensure that these 6 rights are always followed. Yeah, and she says definitely. They happen. We had one, and I'll share it again. We had one happen within our family last week, and it could have been, you know, a huge deal, but it wasn't. You know, it's taken care of. But I'll share that with y'all in a little bit. So, the way I remembered this, I just remember things, I guess, in a weird way. But if you're always going to need to remember this, if you can spout out all 6 of those things, that's incredible. If not, I'm going to show y'all a little acronym that I use. It's PD3RT. And it's probably going to be mirrored, which is why I can't teach y'all math. Y'all are seeing it backwards, huh? And this stands for the right patient. Your D's are the drug, the documentation, and the dosage. And then R, of course, is route, and T is time. So if you say it in your head 1,000 times, PD3RT, 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 you'll hear my annoying voice while you're taking your test. And when I give you an order, or Miss Charlie gives you an order, and it says, what is wrong with this order? And you're staring at this order, and you're like, it looks fine to me. It looks like it's all there, and I don't think anything's wrong with it. You should be able to check off all of these things to ensure that, yes, they told me what patient. Yes, they told me, you know, all of these other things. Does that make sense to you guys? So if I said, I'm going to give y'all a quick example before we move on. If I said Tylenol twice daily, and this is for Miss Sabrina Charlie. Sorry, I'm going to use you 1,000 times as an example. Okay. Sabrina Charlie, Tylenol twice daily as needed. Can anybody type in the chat bar? Does that sound like it's everything that we might need? Or what are we missing? That's what we're going to be doing, is determining what we're missing. What we're missing. I appreciate y'all typing in the chat bar. I know it's not as personal as being in class, but I appreciate it anyway. Okay, so the right route. So that I have a couple people saying the right route. So we're missing the route. So Tylenol can be given a lot of different ways, right? Tylenol can be given PO, which is by mouth. Did y'all learn those in med? Sidestep for 1 second. Do y'all know all, like, what PO, SL, do you know all those terms? Y'all learn that in terminology? Okay. So those are subject to be brought out on any test. If you don't know them, you need to brush up and review, okay? Y'all know BID, TID, all that stuff? Okay. If you don't, or you're like, oh my God, Miss Charlie, what are you talking about? Then shoot me a message and I'll upload y'all a file, but it's absolutely abbreviations that you're going to need to know. So as far as the route, it can be PO. It can be, it can actually be given IV. It's not as given as often, but we used to give affirmative in the surgery department. It can be given rectally. And it could be given, what? Is that it? PO, IV, rectally? I think that's it. And then somebody else said we're missing the dose. So we could be given 1,000 milligrams of Tylenol. Or we could be given 125 milligrams of Tylenol to, you know, to a younger person. So y'all can see. And then there's one other thing that's missing. Does anybody know? I don't think anybody said it yet. Documentation, yes, and time is the one that I was really looking for. As needed is not sufficient. We need something measurable. If I told you go take your anxiety medicine as needed. This first week of school, it's probably as needed every 5 minutes, but you would overdose if you did that, okay? So we need to know as needed Q4 hours, Q6 hours. So that's important. So very good job. So anticipate on all your tests throughout that you're going to need to identify what is missing. You know, what is, because if you can't, your job as a nurse in the setting is to call and clarify orders. And doctors will get mad at you when you call and clarify. You know, but your job to truly determine, you know, to do your due diligence is to make sure that if it's missing one of those 6 rights, or the documentation is on you. So if it's missing one of those 5 things, then you need to clarify. Any questions? So how are we going to do that? How are we going to make sure that it's right? If we need to ensure that it's the right patient, by having the patient identify themselves in 2 ways. We're going to check their armband. That's why people in the hospital setting get incredibly annoyed. But if they're getting incredibly annoyed, it means that the nurses are doing their job. You know, if they know when you walk in, I'm going to show you my armband again, then the nurses have been doing their job. For me, I like that personal touch of nursing. So I'll kind of make it like, it does get annoying because obviously if you've been taking care of your patients for 7 days, then you know who they are and you can probably remember their birth date by heart. But I'll just kind of preface it with, hey, you know, I know who you are, but let me check that armband and scan it, or, you know, and I'll still be checking it, but I won't make it like, please state your name and date of birth. But you're still checking your name and date of birth, and you're checking your patient. Never ever take for granted that that is incredibly important, especially as you begin to be stressed out in the field and you're given medications to multiple people and they're on a lot of the same medications. So the right drug, compare the medication, container label, and medication record. So let me tell y'all want a story? Y'all want a little quick story about how this looks in real life? Okay, so last semester before, I don't know, they all meld together, but one semester that I did clinicals recently, take a sip of water. One semester that I did clinicals, I was with the juniors, and we were given medications. And so we're going to talk about, most of y'all, if you've been in the hospital, you've seen the newer age where they scan the armband and then they scan the medication. And that's one way that we're ensuring that all these rights are met. But it's not foolproof. And so what I want to tell you is a little example of how it wasn't foolproof. We were doing MedPass. They had been through pharmacology already. And, you know, I was hovering over, I'm like, you know, because it's under my name. So I'm like, okay, you know, I'm behind them and I'm checking off everything. And so sometimes medications are not going to be in the hospital's formulary. And if they're not in the hospital's formulary, that means that the medication, the hospital doesn't have that medication, or it's going to take several days for them to get that medication. So the physician will write an order, okay to use home med. When a physician writes that order, what happens is they bring the medication from home, and the pharmacy prints out, you know, one of the little scannable labels, and they usually put it in, because the home medication already has the label from the original pharmacy, right? Y'all with me? And so the hospital will print out, they'll put a little Ziploc bag, and they will print out a label, you know, their label that has the medication on it, and they'll put that medication in the Ziploc bag. So we're pulling meds, and we're scanning with our little doodad, and everything went through, and we scanned it. And so when we brought the medication into the patient's room, and we took the CVS bottle out of the Ziploc bag, we were checking it. The medication that was in the Ziploc bag was not the same medication as the label that was on the outside of the bag. It was a different medication. So that patient, y'all, anybody want to guess how long that patient was in the hospital? 3 weeks. They got the wrong medicine for 3 weeks. And technically, the nurses were checking that label. You know what I'm saying? That label that said on the outside of that bag, but they didn't check the label that the actual medication was in. So in a 3-week period, you're probably talking And I'm not talking about them at all because I've made med errors too, and I'll share those with you. But you're probably talking 20 nurses that drop the ball. And that's real life, happens every day. So that particular medication was a medication that was prescribed to that patient. It wasn't like a random medication. It was a medication that her family brought from home, but it wasn't the medication that was ordered by the physician, and it wasn't the medication that the nurses were documenting that they had been given. So just know that you can really never check too many times, okay? Like, because it happens. It truly, truly happens. And when I share those numbers with you, you're going to be like completely blown away. They don't even seem like real life numbers. So that's what we're going to do. The right drug, we're going to compare the medication, the container label, and our medication record. And of course, y'all know medication record is the MAR, medication, MAR, medication administration record. We need to ensure that it's the right dose. So for that particular medicine, they were both 10 milligrams. The right route, they were both oral. They were both given twice a day, but it was straight up the wrong drug. And then, of course, the right documentation. This here where it says record immediately, I want to point out to y'all, when meds are given at change of shift, people get in a hurry to go to the house because they've been there for 12 hours. And so if your patient can have medication Q4 and you either document before you give it, so like let's say your patient can have Lortab Q4 for pain, and you're given medicine and you're fixing to get off, and at 6:50 you go in there and he says, hey, I'm hurting, can I have my pain medication? And you're like, yeah, it's due. You determine that it's due and you go give it to him. You pull it out of the Pyxis, but you forget to document it within your MAR. And so whenever your nurse that's following you, she makes her first rounds and he says, yeah, I'm hurting. And you didn't document that you gave that medication. You acknowledged it. You gave him the right drug, the right dose, the right route, all that good stuff, but you failed to document it. And your nurse goes and pulls it. Then y'all gave your patient the medication twice. So there's safeguards in the Pyxis that say, this medication was just administered. Are you sure you want to pull this medication? And a lot of nurses will just override. So if ever you're pulling something out of the Pyxis and it asks you to clarify, take the time and clarify. Exit out of the Pyxis, go ask your patient, hey, did you get this medication? Call the nurse that just came out, and clear that up before you go overriding something, okay? And it doesn't always have to be pain medication. It could be a lot of things. All right, questions right now. Okay. So drug administration considerations. As a nurse, and I've probably already said all this stuff, because I'm kind of bad at just talking and not flipping through my slides. So considerations that you need to have as a nurse is factual knowledge of each drug given, the reasons for use, general actions of the drug, common adverse reactions, special precautions in administration, and normal dosage ranges. So the more familiar you get with giving a medication, you'll know that a normal dose of Tylenol is anywhere from 500 to 1,000. So if somebody orders 2,000 milligrams of Tylenol, you might take a step back and say, that seems like a lot. Let me clarify. Always use your judgment. You want to check current and approved references for all drug information, which we talked about. Drug books, I think I had told my accelerated class this yesterday, and I didn't get you the document that I told you that I would get to you. I'm going back up to the school today, so I'll do that. It's a good idea to have a drug book, even if it wasn't on your book list, like a Davis drug guide or something like that, because when you go to clinicals, you're not going to be able to have your phone, and you're going to need to be able to look up some drugs that you're not familiar with. So check those current and approved references for all drug information. When you're given meds in the hospital setting, I don't think I've ever worked at a place where it wasn't on the computer where I could do a drop down and locate my medication and look up some information like on Lippincott or something. Miss Charlie, have you had a different experience? You pretty much have all those resources available to you in your work setting, right?
Yeah.
Yeah. So, and it's your job as a nurse too, if you don't have the resources you need, to make your superiors aware of that. So consider, before administering a drug, the patient's allergy history, previous adverse reactions, patient comments, and a change in patient condition. Patient comments are important. Sometimes patient comments are, we let them go in one ear and out the other because A, they're a drama queen, or B, whatever. But in medication administration, I had mentioned yesterday to my class, if they're telling you that they, last time they had this, that their eye was a little bit itchy, you're not going to wait, several hours before you go check on them after administering the medication. You're going to go peek on them after about 30 minutes and make sure that, they're not having an allergic reaction. You're going to need to take into consideration the guidelines for preparing a drug for administration. So when you're given sub-Q stuff or you're giving IM injections, so sub-Q, some of your stuff needs to be refrigerated. You need to take that into consideration. If it's been on the counter for, 12 hours since yesterday, you might ought to call the pharmacy and confirm some things. If you are preparing a drug for administration and the instructions say to mix it with sterile water, make sure that you're mixing it with sterile water and not saline. So just keep those guidelines, remain knowledgeable about those guidelines. Check the healthcare provider's written orders and compare the label of the drug with the MAR, and wash your hands. Do not let your hands touch the capsules. All right, questions? Mighty quiet. All right, drug administration considerations continued. Never remove a drug from an unlabeled container or a package Never remove a drug from an unlabeled container or a package with an illegible label. So, when I first became a nurse and I was a charge nurse, and I was given pushes for some of my LPNs, they would just bring me a syringe with stuff in it. Can't do that. You need to label it. You need to draw it up if you're going to give it, okay? Never crush tablets or open capsules or administer a drug prepared by someone else. Alert drugs with similar names. And return drugs requiring special storage to the storage area immediately after they are prepared for administration. All right. Further considerations. Each time a drug is prepared and administered, follow the 5, or let's just say 6 rights. Precautions taken by the nurse are to confirm any questionable orders, verify calculations with another nurse, listen to the patient, and concentrate only on one task at a time. I am a little bit scatterbrained. That is one thing, and I'm pretty serious about. If I'm given medications, I really do tell people, hold on just a second. Like I want to focus on what I'm doing at hand there. Let's see. And the most common occurrence of medication errors happen with insulin and heparin. Medication errors. Be mindful of the time to administer medication. A physician's order is essential. Look for common orders such as standing orders, single orders, PRN orders, stat orders, or once a week orders. That can be referenced. Go to page 21, that little box at the top. You need to know the difference between those. Page 21 on Roach's introductory. Sometimes a doctor will want a medication given every day, but when he gives that single order, it'll just say, to give it, but it won't be like a recurring order. It won't say, daily. So sometimes you'll have to clarify things like that. All right, so this is an example. I'm sure y'all have seen a lot of these things. The one, I'm scrolling on my thing. Y'all can't see my mouse. Can you see my mouse? No? Okay. I'm like circling stuff to point to it, but y'all can't see it. This little rolling cart is the type of drug dispenser that you might see in the nursing home setting. And those medications are administered different. They're like in a little punch out card, and they don't come out one at a time for those residents. And then in a hospital setting, you'll usually see something like this. It's either called a Pyxis or Omnicell. Have you ever heard any other brand names, Sabrina? So sometimes Pyxis and Omnicell are brand names of these drug dispensers, the computerized dispensing systems. So sometimes somebody might tell you go to the Pyxis and it's an Omnicell or whatever, vice versa. Just know they're talking about the computerized dispensing system where your drugs are coming from. We usually use barcode scanners to decrease medication errors and unit dose systems. Okay, so oral medication administration is the most frequent route of drug administration. Oral drugs can come in tablets, capsules, or liquids. They're usually sustained release drugs, and then the nursing responsibilities are to verify the drug, identify the patient, assess, keep water readily available. Don't go in to give your patient meds and you forgot their water, because then you're leaving out with your meds and you're having to come back. So try to go in, be prepared, instruct, and never leave a drug at the patient's bedside to be taken later. So I ran into this last semester too. Had a patient, there's some medications that have to be given. If you're on dialysis, they have to be given with meals or they're completely ineffective. So my student went in to give the medications and he's like, just leave them right there on the table because I can't take them until I eat. And she come out and she's like, Ms. Traylor, he wants me to leave his medications on the table. And so in the particular setting that we were in, I know that some nurses had been doing that because he was he was 45 years old and he's been on dialysis for 20 years and he really knows how to care for himself. And yes, he was correct that that those medications need to be administered with meals. But at the end of the day, you're the person leaving those pills on the table available for anyone, and that is not acceptable. So he was irate. The charge nurse had to get involved. But at the end of the day, my student nurse was doing exactly what she was supposed to do by not leaving those medications at the bedside. So don't let your patients sway you into doing stuff that you know is wrong, okay? Any questions about that? Parenteral, I can't get it out. Parenteral drug administration routes is basically anything other than oral. Subcutaneous, which is in the fatty tissue. Intramuscular, obviously in the muscle. Intravenous within the vascular system. Intradermal is through the skin. Intralesional, can't say that I know what that is. I'm assuming it's like lidocaine on a lesion. I have to look that up. Any thoughts, Miss Charlie? I don't even remember seeing that previously. Sorry. So, surprise, there's a new word. I'll look it up for y'all. I'm thinking it's like lidocaine to be given within. No, a patch would be intradermal. It's absorbed through the skin. But that's a good thought. So intradermal is an example of a patch. I appreciate that very much. I'd like for y'all to communicate me with it through the chat bars. It shows me that you're thinking and you're paying attention. Intracardiac, intra-articular would be like joint injections, and intra-arterial are medications that are going to be given like during surgery. Nursing responsibilities are to wear your gloves, use standard precautions, and of course you're going to need to clean the skin if you are giving, if you're given anything that, excuse me, I should have lost my train of thought. If you're given an injection or anything, you're going to always cleanse the skin. Let's see, I have a chat in the chat bar. Oh, Lordy, everything went away. Hold on. Ashley Good, an intralesional injection is the direct injection of a therapeutic substance into a lesion on the skin. Perfect. Thank you for looking that up, Ashley. So that would be like lidocaine. Before you give stitches, put in lidocaine to numb it up. Perfect. I appreciate that. All right. Subcutaneous route. You need to memorize these locations. And this is basically, if you think of fatty areas, stomach, the fatty tissue on the thigh, the fatty tissue on the back of the arms, not in the muscle, but let me show y'all. Take off my, let's see. I'm stuck. This fatty area, see this fatty area? It's not the same as the muscle right here. All this fatty area right here. I'm showing you all my fat arms during a lecture. Abdomen, the squishy areas are your subcutaneous areas. You need to, administration of drugs by subcutaneous route places the drug in the tissues between the skin and the muscle. Volume of the injection matters. And then, I already told you that, upper arms, upper abdomen, and upper back. I have never in my nursing career given a subcutaneous injection in the back. But there is fatty tissue back there, so whatever floats y'all's boat. Your patients might look at you like you're crazy. Sabrina, you ever given an injection in the back? On someone's back? Yeah. Good to know. See, I never have, so that would be that makes sense. And actually, when they do allergy testing, they do that on children's back as well, so that makes sense. Let's see. The needle length is going to matter. If your patient is obese, you'll have to go a little bit deeper just to get through the skin. If your patient is very thin, you may not need to go in as deep. And when you're given a sub-Q injection, you're always going to go in at 45 degrees. Intramuscular route is the administration of drugs by the intramuscular route, obviously, and it's going into a muscle. Your nursing responsibilities. You're going to have a 22 gauge needle. Well, your needle gauge is actually going to vary, so it's not just a 22 gauge needle. It depends. There's several things that, let me see if my next slide tells you. No, it doesn't. This is just really brief. I'll share a slide with y'all. The gauge of your needle is going to be determined based on the viscosity of your medication, how thick it is. It's also going to be determined by the size of your patient. The length is going to be determined by the size of your patient. So obviously the larger the gauge, the more comfortable, but you're not going to be able to give an intramuscular injection with a 24 gauge needle. So I will share a PDF with that. Let me make myself a note. And like I told them yesterday, if I tell you I'm going to share something with you and then it doesn't get shared timely, I will not get mad at you if you say, hey, Miss Traylor, where's that document you told us you would share? Because throughout the day, a lot of stuff comes up and it doesn't happen until midnight. So a PDF of needle sizes. Okay. So nursing responsibilities, you need to ensure that the volume is correct. You need to make sure that your needle length is appropriate. Your angle of insertion is going to be 90 degrees. You're going to either use the deltoid muscle, the ventrogluteal muscle, or the dorsogluteal sites, or the vastus lateralis. And all of those are documented as well. And when y'all come in for lab, I have the hiccups, we'll be able to point those out and show you exactly where they are. But I definitely want y'all to watch the videos that are posted, that we post to y'all with these sites so that you don't come in clueless. The goal is that when you come into lab, we're showing and we're walking you through, but it's not all completely foreign. When you walk in the door, you have a general idea of where you're going to be practicing these injections. And no, we're not going to practice on each other. And then the Z-Track technique is a way of giving injections that prevents backflow of a drug into the subcutaneous tissue. And we'll demonstrate all that further. This is kind of just an outline to get you started. All right, the intradermal route is whenever you're given something like a TB skin test, like Miss Charlie said, it's going directly under the skin. It's not going into the subcu tissue, it's going under the skin. And it's given on the inner part of the forearm. And she said she gave hers on the back before, on the upper back, to avoid areas with skin problems. So like I have eczema real bad. So we always have to try to find a spot on my arm that, is nice and clear. So don't give it in an area that, already has a lesion or an issue on it, burned, stuff like that. Now this, gotcha. Yeah, and I appreciate that because I've never done that in my nursing career. So that just goes to show you that, you know, nursing judgment had to be used there. So we haven't talked much about fistulas yet, but when someone has a fistula, you can't stick them on that side. Um, and not only can you not stick them on that side, you're not supposed to do blood pressure on that side. It's in the way. Like it's blocking the area you need to get to. And then, like she said, wounds on the other side. So it just couldn't be done. So intradermal injection is going to go directly, it's going in at a 15-degree angle. And you are going to, this is the one where you want to make a little bleb. And we'll kind of practice that in class as well. But you see that little bleb there in the picture. We want that medication to be visible under the skin. And this is used for TB skin test. All right, the topical route is administration of drugs by the topical, I need to stop reading this one because it makes it awkward. Administration of drugs by the topical route on the skin. It's not absorbed through the skin unless, I want to add a little disclaimer here. It's not absorbed through the skin systemically, but if it's misused or applied in places that are highly vascular, it could be absorbed. So that's something that as a nurse you want to take into consideration. So drug action may depend on correct administration of the drug. So topical things would be things like, Neosporin or steroids, stuff like that. All right. The transdermal route, as we briefly discussed earlier, is administration of drugs transdermally. They are absorbed from the skin. The dosage is implanted into a small patch-type bandage. The drug system maintains constant blood concentration, so the transdermal is definitely absorbed systemically. And it reduces the possibility of toxicity because it does release it in a time-release fashion. When you put on a transdermal patch, you always want to wear gloves. You want to apply the patch to clean, dry, non-hairy areas of intact skin. And you want to, you need to document when you put it on there and when, like, put your initials on the patch and the date. And then you also want to do that, document the location that you put it within your chart documentation. Commonly used sites are the chest, flank, and upper arm. Funny story about that, was working pre-op. And one of the medications that we give in pre-op is a scopolamine patch. We put it behind the ear. We use it to prevent nausea and vomiting. And it's just a little bitty, patch, and you put it behind the ear. And so my friend, like, throughout the day, she was like, Brittany, I can't see. Like, I don't know what's wrong. Like, I feel like kind of dizzy and I can't see today. And so I looked at her and one of her pupils was like humongo. And I'm like, what is happening? So she went and talked to the anesthesiologist and he's like, he was like, did you put a scope patch on today? And she said, yeah. And he said, did you wear gloves? And she was like, maybe not. And she had touched the patch and then rubbed her eye and it had a reaction, of the medication that was on her fingers had a reaction and dilated her pupil. It was nothing that was long lasting or anything like that. But it had absorbed and got on her skin and dilated her pupil. So that's a pretty funny story. It was funnier when you were actually there because she thought she was going blind and she was being super dramatic. Inhalation routes. Drugs are administered through the inhalation route. They can be droplets, vapors, gas, and they'll go through the mucous membranes. You can use a face mask, a nebulizer, positive pressure breathing machine, any of those things. The biggest thing here is that, especially like all these inhalers, I don't know how familiar y'all are with inhalers, but they're all actually a little bit different. It used to just be like a regular albuterol was like puff, breathe in, no big deal. Some of them you have to pull down and you have to slowly inhale the powder, and then you have to rinse your mouth out afterwards. And we'll go into all those specifics later as we talk about those specific drugs. But it is important that you take all of those things into consideration and that you know how to instruct your patients properly. All right, we can give eye drops, ear drops. So eye drops are ophthalmic, and ear drops are otic preparations. And we will show you videos on how to correctly instill those as well. Oh, I got a story about that. Listen to this. So my friend works at an eye doctor, and she was on the phone, and she was like, I was talking to her on her lunch break, and they had called her from work, and they were like, we need you to come back now. We need to get a patient transported to the ER. We need you to call EMS, whatever it was. I don't know if it was EMS or whatever. But needed you to call the ER and let them know what was going on. That's what it was. And so she was like, I gotta go. So she, of course, didn't tell me anything about the patient or anything like that. But she did tell me that someone accidentally, y'all know the nail glue that you glue nails on? A patient mistakenly put nail glue in their eye instead of their eye drops, and like all kinds of bad stuff happened. But the bottles look the same, right? When you're sleepy in the morning and you just grab something and it's just that as soon as she did it, obviously she knew that she did it. So stuff like that happens every day, y'all. Crazy, huh? Can you imagine? Does that make you hurt just thinking about it? Like, I can't even think about my eyelid being stuck to my eyeball. It just grosses me out. So regardless of the medication administration type, route, whatever location that you're administering it, facility, it is always your job to monitor the response of the patient and to document accurately. All right, that is the end of that chapter. I'm going to go ahead and ask me questions real quick. I'm going to stop this recording so that we don't have another 2-hour recording. Y'all have any questions? Nobody? Okay. So I'm going to stop this recording.